Hi, good morning or good afternoon, depending on what time you're watching this podcast. This is the October podcast for Paramedical Personnel in Maryland, or PPM. And a lot of questions have been coming in reference to AEDs. And so that's what we're going to go over in this podcast. So it won't be that long, but certainly I hope you glean a little bit of information from this and hopefully correct some of the mistakes I'm seeing in the field. A little quickie history lesson here. 1899 was the first time that they were actually working on a defibrillator, and that was by a physiologist by the name of Jean-Luc Provost and his sidekick Frederic Bertelli. And that was when they were first working on something similar to what we would have today in the big carts that roll in as a defibrillator type thing. Not really an AED. It didn't have any computer capability because they didn't know what a computer even was back then. So it was way too early for anything that really resembled the AED. And it was first used to restart a dog's heart because, as you know, that's where most of the lab work was on animal research and proved that it could actually restart a dog's heart. And then it kind of sat dormant because nobody really kind of thought this was a good idea. And it wasn't until, 1947, where a guy by the name of Claude Beck was the first one that actually used it on a 14-year-old boy. And the boy's heart had stopped, and he actually ordered them to go down to the basement and drag this machine up that he had seen somebody play with and use, and thought, well, let's give it a try. On the second shock, he restarted the boy's heart. Now, notice we say restarted. Chances are the boy's heart was still in ventricular fib, and second shock actually got it back into its normal rhythm. So back then, they were still wondering, how this even worked or what it even was. Okay, then let's fast forward to 1956, when the actual first kind of mobile defibrillator was actually made, one more similar to what we're used to, and that was by Paul Zoll. I don't know if he was a PhD type doc or what, but Paul Zoll was the one that demonstrated external defibrillation. So very similar to what we're doing today, pad, and a shock through the patient's chest. So all the previous ones, they actually had to do open chest and apply the pads directly, or the connections directly to the heart muscle. So this is the first one that was actually used external and proved that it could work. So it wasn't until 1978 when they actually started producing the very first AEDs of kind of modern time that we see today. Okay, so there's kind of a timeline there. So we're well into the AED world as far as recognizing the importance of AEDs and how much they do save lives. Early use of an AED can increase success rate dramatically, literally through the roof compared to CPR by itself. Now let's talk about some issues that I'm seeing. First of all, a lot of people, or a lot of instructors, when they're teaching their classes, have the AED trainers already plugged in before they turn them on. Well, problem with that is the AED thinks the pads are already on the patient. So it's telling them, it's analyzing the patient, and the pads aren't even on the patient yet. The student's standing there with the pads in their hand. So no, nothing plugged in. Turn the AED on.
Apply pads to patient's bare chest. Plug in pads connector next to flashing light.
Okay, so that's what your student should hear right off the bat. They turn the AED on first. It tells them to put the pads on the patient. Okay, and again, pads upper right, lower left. They can look at the pictures on the pad. It will tell them where it goes. Okay, then they plug in. Now, a point of reference for where the pads go. If they reverse the pads, upper right, lower left, but the opposite pads, all AEDs have the ability to reverse the polarity. So to reverse the EKG, so it's now correct and it can read it correctly. AEDs are designed to read lead 2 presentation. Here and here is lead 2 presentation. That's why you can't put it anywhere else on the body, because it can't read it. Lead 2, here and here. Okay? So that's one of the biggest problems we're seeing, is that many times they already have it plugged in, and it causes total confusion for the student. And again, we want the student to hear the thing say, apply pads to patient's bare chest. The other thing we're running into here is on the infant. As you know, American Heart says that the pads have to go anterior, posterior on an infant. Remember, we're using pretty much adult pads anymore. Peds pads you won't even find in most of your AEDs. But if you're using a pediatric baby mannequin, okay, which we have here, the infant mannequin, I see people sticking the pad on the clothing because the mannequins, really, the Laerdal mannequins, aren't really designed to stick a pad on. So they're putting it on the clothing. Well, that's a big no-no. Because remember, whatever you do, your students are going to follow what they saw you do, which means in real world, they're going to stick it on the infant's clothing. So stop doing that. Stop sticking it on the clothing. If you're going to put it on the infant, it's got to be on front and back, the way HA says. Not necessarily that I'm wild about, but it's what HA says. So stop sticking it on clothing because that's what your people are going to do. Okay, be more realistic. In that case, you can get any old baby doll from a store that you can actually stick front and back on, and it's also easier to clean. Obviously, you can't do CPR on it, but it's a good show of pad placement if you want to do something like that. The next biggie that's coming up is the thing called movement. And I've explained this to a couple of my instructors already, and yet it still seems to be coming in, so that's why we're adding it to the podcast. AEDs look for a lot of things. They're looking for the rhythm of the patient. As you know, it only has two rhythms that it shocks. It shocks ventricular fibrillation, which is the most common, and a VTAC in excess of 280 beats per minute. Now, why 280 as a safety factor? Well, that's because at 280 beats per minute, your patient will be unconscious. And we don't want to have this thing armed to fire with a person talking to you. Okay, so that's the two rhythms it shocks. If it sees anything else, if it sees asystole, it says what? No shock advised. If it sees some bizarre and strange rhythm, it will say no shock advised. So it only looks for two things. If those two things aren't present, if anything else is present, no shock advised. Okay? So now what's happening? Well, someone came up with the idea, and who I'm not sure, that when this thing says shock advised, charging, that we should run back and begin compressing the chest of our patient. Well, remember, these things are still analyzing the patient. Even though it's done its initial analyzing and said, aha, this patient's in ventricular fib, I'm going to charge, it's still monitoring that patient. So when you start pushing on the chest, this thing is going to say, wait a minute, something just changed. I see movement. And it will disarm and turn off because it assumes that this patient's got some type of other rhythm besides its viable rhythm that it's going to actually shock. So, do not touch the patient. Let it go through its cycle, arm, fire, and then go back to CPR right off the bat, right after the shock. Do not try this ahead of time. You cannot hold this in the air. I've heard people say, well, just hang on to it in the air. No, it's going to detect movement of the device. The device cannot be in a moving vehicle and operate. It will detect the movement in the vehicle and shut off. So no, it's got to be standard, stable in one spot, connected to the patient. Do not interfere until after the shock, then go back into CPR. Okay, I'm hoping I'm making that clear enough because that seems to be a real problem. Everybody wants to jump back on the chest. And many people, when I say to them, you do realize you're going to trigger a movement alarm, they go, what is that? Okay, so they've never been taught that. If you look in your owner's manual for any of your AEDs, whether it be your LifePak 500s or your newer ones, if you look in the owner's manual and look under movement, you'll see it written in there. It's in the manuals about movement and not to move the vehicle, in a vehicle, moving vehicle, and certainly not to do anything that's going to have this thing detect motion. Okay, so I'm hoping I make that very clear to you because that's been some real issues that we've run into, both watching it and then the questions coming in. Okay, so I'm not sure who started that concept of let's try to get 5 more compressions in because you're literally going to screw the whole thing up. Okay, so AEDs work fantastic. They were designed. A lot of things were thought of prior to, and certainly if they wanted us to do those extra compressions, that would have been in there from the very beginning training. Okay, so there's reasons why we don't do certain things. And again, if you got questions like that, please feel free to call. Those calls have what's prompted this kind of impromptu addition to my normal to make sure that people are understanding how to use this AED. Okay, they work fantastic. Can't say enough about them. Been pro AEDs since they first came on the market. One other thing that I'll add to this too is in the old days, the AED pads were really sticky. Okay, you could practically put those suckers on underwater and they would stick to your patient. Nowadays, they're not so sticky. So the old theory of put a pad on and rip the hair off used to be true for the old pads. The new pads really won't do that. But they have come out with a new little creature, and it's a hair removal pad. They're really cheap. AED Superstore is the one I always recommend people go to. I get no commissions from them. But they're the first ones that actually saw a little plastic shield that you put with your AED stuff. And if the guy is very hairy, you stick it on him and then rip that pad off. It's like waxing a patient. And it literally takes all the hair off the size of your pad that you're going to put on. So you don't wreck a $150 pad, and you got a good clear spot here and here to put your pads on. Okay, now I've used pads on pretty hairy patients, and I've never had it say check electrodes. They've always worked. Okay, so it is kind of odd when that does happen, but these little plastic things are super cheap, a lot cheaper than a whole set of electrodes or another set of pads. Okay, so I recommend them to get some, put them in all your AED out there so you've got something to use, because that little Bic safety razor really doesn't cut it on a real hairy patient. Anybody's ever prepped a patient with a Bic safety razor understands the problem you go through trying to get that hair out of your way. And remember, time's the killer here, so you don't have a day and a half to try to prep a patient. Got to be quick, got to be fast. Okay, that pretty much wraps it up for this one. Again, keep your cards and letters coming in. Again, special thanks for all the ones that came to our instructor gathering. 2 great speakers, both of them, the one that did CPR on the cardiac arrest and the cardiac arrest herself. Fantastic speakers, explained really what it felt like. And then, of course, our person from Maryland, in discussion with Narcan, fantastic speaker in reference to that too. So 2 great speakers, good food as always. And again, thanks for the 64 that actually came to our instructor gathering. We're planning now for the next one, so if you got ideas or speakers or suggestions, let us know so we can get that planned in and get that in the works for next year. Okay? Again, thanks for watching, and I'll see you soon. Bye.